like to welcome you to today's seminar. It's part of our amazing alumni series. This is a series that was started by Bob Blum when he was chair of the department, and there are many notable former presenters, and they include Anita Chandra, Vignetta Charles, Andrea Crania, who's an associate professor at the school, Donna Peterson, a dean at the School of Public Health in Tampa and the University of South Florida, and Chessie Polis. And I'm sure that many of you know their names. I'm delighted to introduce today's speaker, and I wanted to let you know that she is, the lecture is pre-recorded. She is in Australia. So it is the wee hours in the morning for her. She is going to join us for questions at the end of the seminar. The seminar is about 47 minutes long, so you will have about 20 minutes to answer questions. We are delighted to introduce Meghan. She is a superstar. She's currently a senior lecturer in gender and women's health at the University of Melbourne, where she has been since 2018. She received her Master's of Science in Public Health from our department in 2012 and her PhD in 2016. During the time between her master's and then completing her PhD and into 2017, she was a consultant with WHO, and a lot of her work that deals with gender issues and women's health, in particular respectful maternity care, was based on collaborations with WHO, and she very much spawned that research area, and she has covered it not only in looking at qualitative research, but also quantitative research, measurement. She does a lot of other work in quality of maternity care. So I'm absolutely delighted to introduce her.
Hello, everyone. I'm speaking to you today from Australia. In Australia, it's typical to begin sessions like this with what we call an acknowledgement of country. This is a way of showing awareness of and respect for the traditional custodians of the land upon which an event or meeting is taking place. Therefore, I'd like to begin today by acknowledging the elders and descendants of the Wurundjeri and Boon Wurrung people of the Kulin Nation, who are the custodians of the land I'm on today. I acknowledge that the land I'm on is a place of age-old ceremony, of celebration, initiation, and renewal, and that the Wurundjeri and Boon Wurrung people have had and continue to have a unique role in the life of these lands. My name is Meghan Bohren, and I'm really delighted to join you today for the PopFam Noon Seminar. For those of you who I don't know, I'm also from PopFam roots, as I completed both my MSPH and PhD in the department in the last 10 years. It's an honor and a privilege for me to be back today, even in the remote environment. Thank you also for bearing with me with the pre-record, as Noon Seminar is unfortunately at my 4 a.m. and isn't my best time to shine. Today, I'm going to talk to you about some of my work on sort of two topics. The first is on why women's experiences of pregnancy and childbirth care matter, as well as some of our research on the mistreatment of women during childbirth. Many of you will be familiar with the WHO vision and framework for quality of care for pregnant women and newborns. This framework posits that within the structure of health systems and health facilities, processes of care influence outcomes. These processes of care can further be understood as both provision of care and experiences of care. Provision of care refers to care that is evidence-based practices for routine care and management of complications, actionable information systems, and functional referral systems. These are perhaps the more commonly known aspects of quality care. Experiences of care, on the other hand, refer to how patients, in this case, women, their families, and newborns, experience care, and typically understood as effective communication that meets their needs, respect, preservation of dignity, and emotional support. Underpinning both the provision and experience of care domains are competent and motivated human resources and essential physical resources available in each setting. Historically, most qualitative quality improvement, interventional, and research work across obstetrics, midwifery, and public health has focused on improving the provision of care, so focusing this area on the framework to the domains on the left side of the screen. Comparatively, we know far less about how to improve experiences of care, and today we'll talk a bit more about some of our efforts to address this. I really love this quote from Professor Pathala, who is an obstetrician and former president of FIGO, the International Obstetrics and Gynecology Association, as it's really grounding to me in this work. And importantly, it really shows that understanding of how and why experiences of care matter isn't really actually a new concept at all, despite the fact that we still have so much to learn about it in the last 2 decades since he spoke. Prof. Pathala says, the question should not be why do women not accept the service that we offer, but why do we not offer a service that women will accept? So just to sort of get started and get us situated here, let's talk a bit about what is a positive birth experience. WHO has defined a positive birth experience in their most recent guidelines on childbirth care. And they've defined positive birth experiences as experiences that fulfill or exceed women's personal and sociocultural beliefs and expectations about pregnancy and birth, including things like giving birth to a healthy baby in a clinically and psychologically safe environment with continuity of care and, importantly, emotional support. This is based on the premise that many women would like to have a physiological labor and birth, and they'd like to have a sense of personal achievement and control throughout involvement in decision-making, even when intervention is needed or is warranted to save her life or the life of her baby. So why do these positive birth experiences matter? So the mistreatment of women during childbirth is really about denying women autonomy and agency. And different types, or even the same types of mistreatment, can occur and have different and multiple causes. So for instance, the denial of pain relief during labor might be due to facility level stockouts or systems constraints, which may or may not be due to deprioritization of women's health needs. But they can also be due to intentional or unintentional denial of pain relief due to gendered stereotypes about women and their ability to bear pain. This effort to prevent women from fully exerting full control over their bodily autonomy and decision-making is then also reflected in both laws and practices. Harmful gendered stereotypes, for instance, around women's decision-making competence, women's roles in society, and motherhood fuel these harmful laws and practices that deny women to have reproductive autonomy during pregnancy and birth. Similarly, all forms of mistreatment against women constitute gender-based discrimination, which is often further compounded by other forms of intersectional discrimination faced by these women in the context of pregnancy and birth. So for instance, women from minority racial or ethnic groups, women of lower socioeconomic status, women from migrant or refugee backgrounds, women living with disabilities, and people giving birth who don't identify as women may be more likely to experience intersectional discrimination across multiple different fronts and identities. The power dynamics in the healthcare provider and woman relationship are another root cause of mistreatment. And understanding power can help us to understand how mistreatment occurs and how to best address it. To truly promote respectful care for all, we need to understand and then disrupt these really harmful gendered norms. As I mentioned earlier, experiences of care are equally important as clinical care, but are comparatively less researched or understood. Person-centered outcomes are linked to improved healthcare utilization and health outcomes in many areas, including in maternal health. And lastly, our research has shown that poor treatment during facility-based care, including maternity care, can disincentivize future care-seeking behaviors for both women themselves and for their children's health. So I just want to touch a bit on what's the difference and what's the similarities between experiences of care and satisfaction with care. So we have some work here where we've tried to unpack the differences and the different ways that experiences of care and satisfaction with care can be measured. Experiences of care are what we call process measures, and they typically are reflecting interpersonal aspects related to quality care. Usually in maternal health, these measures around experiences of care refer to things related to effective communication, respect and dignity, and emotional support. In contrast, satisfaction with care are outcome measures, and this means that they reflect whether or not care provided met the person's needs and expectations for that healthcare encounter. And it's important to note that a person's needs and expectations are dynamic, so they're constantly changing throughout a healthcare experience, and they may evolve depending on the way that care is provided to them, as well as their awareness of the different aspects of care provided to them and the outcomes that they achieve along the way. The distinctions between experiences of care and satisfaction with care measures are important to understand in order to make sure that we're best designing and interpreting appropriate measures. Okay, now I'm going to walk you a bit through some of the research that we've conducted in this area. So I'm going to focus a bit now on one study that we worked on at the World Health Organization called How Women Are Treated During Facility-Based Childbirth. And as a bit of a history lesson to understand our context of how did we get here, back in 2013, we had a technical consultation at WHO to develop a global research agenda and to set priorities about what research in this space looked like. This technical consultation was contributed to by advocacy groups, community-based organizations, researchers, and policymakers who are working in the field of maternal health. This technical consultation led to the first ever WHO statement, a position statement on the topic of prevention and elimination of disrespect and abuse during childbirth. And we used the statement kind of jointly as an advocacy piece, but also as a way to sort of leverage future work to be conducted in this area. One of the other main outcomes from this technical consultation was a WHO multi-country study with the purpose of developing and validating measurement tools across multiple contexts. Broadly speaking, this study had three main steps. The first steps was a series of systematic reviews. Then we moved on to primary qualitative formative research, followed by a measurement study. And I'll walk you through each of those different components today. So one of the purposes for a systematic review was to try to better understand the global evidence related to mistreatment during childbirth. So we wanted to understand the context in which mistreatment occurred, the way that mistreatment occurred, as well as how it was measured in different settings. So we conducted a global systematic review using a mixed methods approach, meaning that we were looking for primary qualitative research, as well as prevalence studies and any other types of interventional research that might be present in the area. We identified 65 studies that were conducted across 34 countries. From the prevalence perspective, we had prevalence estimates ranging from about 2% to 98% in low and middle income country settings. And importantly, that these prevalence estimates were really using a wide variety of different tools and approaches to measurement, which might have been also contributing to this sort of wide estimate. When we look to bring together the qualitative evidence, what we were aiming to do is produce a typology of mistreatment. So by typology of mistreatment, we mean we are aiming to present a sort of model and way of classifying different acts that could be considered to be mistreatment from the perspective of women, healthcare providers, and communities. And so broadly speaking, we broke this typology into 6 different domains. First was physical abuse. And so this includes things like slapping, hitting, or pinching a woman when she's in labor. Usually this is occurring between a healthcare provider and the woman. We also found many instances of verbal abuse. So this included things like using very harsh language to speak to the woman, and sometimes threatening her with a poor outcome if, for example, she didn't comply with the demands of a healthcare worker. And also blaming her for poor outcomes. So placing blame on the woman if she was potentially going to have a poor outcome for her baby because she wasn't pushing soon enough, or if she wasn't complying with a requested intervention from the healthcare providers. We found many different instances of stigma and discrimination that took place in the healthcare setting, and the manifestations of what the sort of different identities that were discriminated against varied depending on the setting, but included things like discrimination based on religious status, based on coming from a different ethnic minority compared to the rest of the population that the healthcare service served, as well as disease-specific discrimination. And this particularly was focusing around women living with HIV or women who were pregnant and also had sexually transmitted infections. We found many different instances of where healthcare providers weren't meeting professional standards of care. And so this typically was centering around things like not providing adequate informed consent before examinations or before procedures, as well as breaches of confidentiality of women's private information, either to other patients who are on the ward or to other community members who are present, as well as some really profound areas of neglect. And so neglect kind of manifested in several different ways, including having sort of very delayed care, and also sort of in more extreme sides, having women overcome all of the barriers to give birth in a health facility, only to give birth by herself with no healthcare provider present. We also found many instances of poor rapport between women and healthcare providers. And typically this sort of manifested as ineffective communication. So women weren't really understanding what to expect during labor. They weren't understanding when it was appropriate to push or not and why these things might happen. We found a really profound lack of supportive care. So, there's sort of a more technical approach to the way the care was provided without sort of thinking about the emotional needs of the woman and her family when she's trying to bring a baby to the world, as well as many instances of loss of autonomy. So women not feeling that they were able to control their bodies and what was happening to them. We also found that all of this mistreatment was occurring in the health system that in many different settings had conditions and constraints that inhibited mistreatment, respectful care from happening. And so these health systems conditions and constraints kind of contributed to the experiences of mistreatment, but they could also be experienced directly as mistreatment by women, because when they are encountered with these very sort of low resource healthcare facilities, they were feeling that they were disrespected and that their needs and the needs of their baby and their family were not being accounted for. What these health systems challenges really looked like were things around facility culture. So often this was sort of deprioritizing the needs of midwives and having very hierarchical systems of care where midwives were sort of at the bottom of a very hierarchical structure. We also know that midwives most often are women. And so when you've got these sort of clinical hierarchies at play with women who are midwives at the bottom and perhaps more male doctors at the top, you're having this sort of gender power dynamics play out in a healthcare environment. We also found within the health system that there were often a lack of resources, things like running water, toilets available for women to freshen up in or to use the bathroom, as well as policies that were really disinhibiting women from achieving their full potential. So this would be things like not allowing any visitors to come, not allowing anyone besides a woman giving birth on the labor ward, and different things like this that were sort of creating a disenabling environment for women to give birth in. So these are the sort of different manifestations that we were finding in the systematic review. Then we moved on to conducting a qualitative study. So for those of you who are students now, I will say that the systematic review that I just mentioned, as well as this qualitative study, formed part of my dissertation. So just sort of to show how you can keep working on your dissertation aspects even after you've submitted and graduated. So in this study, we used qualitative methods in 4 countries, in Nigeria, Ghana, Guinea, and Myanmar. Our aim was to explore sort of 3 key factors. The first was women and healthcare providers' perceptions and experiences of care during childbirth. So we were looking at sort of both the positives and the negatives here. What created a positive enabling environment and what could contribute to a disempowering environment, and what are the ways in which people experience this, both as service providers as well as women. We were also interested in understanding from our participants' perspective, what were the factors that influenced how women were treated during childbirth. So these are some of the things looking at sort of what are these drivers that are contributing to these negative experiences that we hear about. And lastly, we were looking to unpack sort of the social norms around how women are treated during childbirth. So we wanted to understand, why were some of these things considered to be acceptable? What sort of circumstances might these experiences of mistreatment be considered acceptable by the population impacted by them? And why were they considered to be acceptable? So we addressed these issues using a qualitative design where we focused on in-depth interviews with women of reproductive age, with healthcare providers, doctors, nurses, midwives who are working in maternity settings, as well as healthcare administrators. So this would be someone who's like the clinical director of a hospital, the head of obstetrics, or the matron in charge of the maternity ward, to try to get that sort of leadership perspective as well. We also conducted focus group discussions with women of reproductive age. And here we were trying to sort of really get into the social norm and community norms about pregnancy and women giving birth and the things that communities expect and will tolerate and also challenge in this environment. So today I'm just going to focus on the results from Nigeria, first of all, because that was what my dissertation focused on. But second of all, if we were to go through all of our qualitative data from 4 countries, we'd be here for a week. So many of you will be familiar with working in Nigeria. From a sort of global maternal health perspective, Nigeria is one of the most difficult places to be pregnant and give birth. There's about 67,000 maternal deaths per year, which accounts for almost a quarter of all global maternal deaths each year. Importantly, Nigeria did not reach the Millennium Development Goal targets for maternal mortality reduction. And as of the last estimates published in 2019, Nigeria still has the fourth worst maternal mortality ratio in the world at about 917 maternal deaths per 100,000 live births. You'll see here also that there's a really wide uncertainty interval in the maternal deaths, and this is because there's huge variation across the country and major challenges with measuring maternal mortality. In Nigeria, women have a 1 in 21 lifetime risk of maternal death. And what this sort of means is that in a sort of most women and most people will know someone who have died from a pregnancy or pregnancy-related cause. The total fertility rate is over 5, so it's quite high. And importantly, there are some huge differences both in fertility as well as in poor maternal health outcomes across the country. So with worse outcomes in the north, which is relatively sort of less developed compared to the south. In terms of maternal health services, about a third of women give birth in health facilities, so this is actually quite low, and about half of women have at least 4 antenatal care visits. So for our qualitative study context, we were working in 2 busy district hospital settings in the Federal Capital Territory. These settings had about 1,000 births per month, which translates to over 30 births per day, so very busy maternity wards. And both of the hospitals were able to provide comprehensive emergency obstetric care. Midwives were the ones who provided the majority of maternity care, and they typically were working in these 3 shifts across the morning, afternoon, and evening. The reason I'm putting this here in this level of detail is not to drive you mad, but just to show you that, you know, during the morning shift, you have about 4 midwives per shift operating, so you're having more than 1 birth per hour. But when you look at the evening shift, which is from 9 p.m. to 7 a.m., you've only got about 2 midwives per shift. And so we know that birth is relatively unpredictable. We don't really know what time the baby's actually going to come out. But you can imagine that with 2 midwives per shift in the evening, this would contribute to a highly stressful environment when over a shift like that, you'd probably be expecting more than 10 births. Importantly, midwives who are working in these health facilities typically are living in the surrounding community. So they're very much a part of the community themselves, and so they might be known to the women who they're supporting. To give you an idea of what some of these hospitals might look like, this is a labor ward at one of the district hospitals in Nigeria. So you'll see here that there are some curtains available for privacy, but they're not necessarily typically used correctly. There's some real challenges with sort of comfort measures related to the bed space. And I mean, at this point, it doesn't actually look too busy there, but you can imagine that the maternity ward would fill in quite quickly. These are some photos of a delivery ward at one of the district hospitals in Nigeria. And so I'll note that when you look at the previous picture here, a woman would typically be in labor, in early labor in this room, and then be asked to walk to the delivery room here for the actual birth. This might be down a hallway. She might have to walk a sizable distance between the labor ward and the delivery room. I also just want to flag here that you'll see that the beds in both of the photos are the short obstetric beds. So these types of beds can limit the woman's ability to move around during labor or to give birth in a position other than lying down on her back with her legs in the air. This is an example of a postnatal ward in the district hospitals. So you'll notice here that there are the cribs in the room with the women. So rooming in is a policy that's practiced pretty regularly there, which is great for things like breastfeeding and bonding outcomes. But there's also quite a lot of beds in this space. So you can imagine it would be a really busy and probably quite a loud ward during recovery. So some of our qualitative findings from Nigeria. We found that physical and verbal abuse in particular were really widespread and acknowledged by women and providers. There was sort of no reluctance to talk about this. It was just a sort of very widely accepted fact that that was what was happening on the maternity wards. We had both women and providers say that women were slapped and beaten to encourage them to have strength. to open up their legs and deliver well. So it was using sort of physical abuse to try to encourage women to be stronger during labor and the birth. We also found some instances where women were physically tied to the bed. So typically this was with sort of like gauze or with strips from a sheet and tying her wrists down to the bed. We also heard a lot of incidents around judgmental comments about sexual behaviors and sexual history. So a really typical thing that we would hear is, oh, you weren't really crying out in pain while you were having sex and enjoying that pleasure, but now you're crying out today and I don't want to hear it. And so these comments about sexual behaviors and their sexual history sort of served as a way of distancing the midwives from the women who they were caring for, as well as this often happens sort of more in the context of unmarried women, adolescents, or younger women, and they weren't really sure how to navigate this judgment. One woman told us that the healthcare providers insult people like they're not human beings. And this quote I thought was really powerful because it's really showing the way that dehumanized care can impact women. In another focus group, women said that women are dying at home because they fear to go to the hospital because of the way the nurses and doctors are treating them. So here we can sort of see the ways that these really negative healthcare encounters can disincentivize using healthcare facilities in the future. I also mentioned that we were interested in exploring the social norms and acceptability of mistreatment during childbirth. And what we sort of found here was that there was really strong consensus between women and healthcare providers that mistreatment sort of out of malice was never something that was considered to be acceptable. So if there was a negative intention to the behaviors, this was not something that would be acceptable by either group. But there were a lot of conditions in which different aspects of mistreatment were considered to be acceptable. And this was things like ensuring a positive health outcome. So what we typically found here was that it was considered acceptable for midwives to slap women when they were in labor, if they believed that they were doing it to encourage the baby to come out well. We also heard a lot of instances, particularly from healthcare providers, that they perceived women to be a bit lazy while they were in labor, which sounds a bit crazy. And so when they're viewing women to be lazy, they would use something like slapping her legs to help her to focus on pushing. So kind of snap her back to attention. It's a way that they were describing this practice. We heard a lot about sort of the word cooperate or uncooperative to describe women who were in labor and giving birth. And I thought this was really fascinating. And even women themselves were saying that when women were not cooperating, then healthcare providers could use physical force or could yell at them to start to cooperate, and that this sort of mistreatment was a bit acceptable because it might be necessary to encourage the woman or to punish the woman for not cooperating. We had one midwife who told us this: by slapping their laps, the patient will know that you truly care for her. After the delivery, you will tell the woman the reason that I did it for you. Even some women will tell you, I'm sorry, thank you. And so here this midwife is really telling us that she feels that the women are understanding that the midwives are maybe pushing them a bit and treating them poorly for their own best interest in mind. And at the end of the healthcare encounter, that women will even come back and say, thank you for providing me with good care. So it's really complex sort of social norms that we were trying to unpack here. So moving on from the qualitative study, now we'll talk a bit about our measurement study. So we used two approaches for our measurement study. The first was what we called labor observations. And here, this would be a woman who was admitted in labor, and we had one woman and one observer to look after her. Our observers were non-clinical, so they had a background either in public health or social work or psychology typically. And the reason that we chose these non-clinical observers was to try to make sure that they didn't have a sort of obligation to provide clinical care if, for instance, the observers were midwives. We also didn't want to, we thought that some of these behaviors related to mistreatment were so deeply entrenched in practice that we didn't want that sort of clinical slant to the healthcare encounter, and therefore viewed the non-clinical observers to be someone who's maybe a bit closer to the woman or closer to the community than a clinical observer might have been. For the labor observations, we had 24-hour coverage, which was very intensive for data collection. but enabled us to not, for instance, truncate our observations because it was past someone's shift time for the observers. So those are the labor observations. We also had a survey conducted with women in the community at around 8 weeks postpartum. And so these women were recruited at the time of their birth. Several of them also participated in the labor observation. And we did the surveys in the community. Again, we were working in 4 countries, so Nigeria, Ghana, Guinea, and Myanmar, same 4 countries as our qualitative study. Okay, so let's look at some of our results, starting with our labor observations. So this is a sort of just quick overview of our design. So we had 9 hospitals in Ghana, Guinea, and Nigeria. We tried to do labor observations in Myanmar, but it was quite a politically complex environment to be working in at that time, and continues to be. And we weren't allowed, therefore, to do the observations and have someone sort of observing what the care environment looked like. The observers observed women continuously one-to-one from the time that they were admitted to the hospital through 2 hours postpartum, or until they were discharged or died, depending on whatever outcome happened first. And so this means that the observer would sort of link up with the woman and then have kind of limited contact with her after she started the observation until the end of that observation period. So she's meant to be just sort of like a fly on the wall. Data collection was about 3 months per site. So as I mentioned, the 24/7 nature of data collection was very intensive for our really wonderful team of observers, but also quite challenging. Also from a coordination perspective, as you have messages coming in around the clock for 3 months about what to do in particular situations. And so these observers were observing and recording interactions between the woman and the healthcare provider, as well as her birth environment, using a structured guide that was on a tablet. We had over 2,000 women who participated in total. And then on the right here, this is just a bit to show you from the sort of research management perspective of what our workflow looked like. And so this is the sort of different order that we had our sort of recruitment and data collection period, as well as the different forms that were used. Okay, so let's start with some of our results from the labor observations. So from our sample of over 2,000 women, just about 42% had observed experiences of physical, verbal abuse or discrimination. Most commonly, this was looking at a woman being slapped, hit, or punched. This is about 9% of women. That over a quarter of women were shouted at, and about 13% of women were scolded for doing something wrong. Among women who had a cesarean section, about 13% of them did not consent to a cesarean section. About a third of women were in labor and gave birth without any sort of curtains or privacy measures that were used at any period during her labor and birth. Over 90% of women in the study had no labor companion present at any time. So no partner, no husband, no sister, mother, mother-in-law to support her from an emotional perspective during this time. Importantly, at the woman's first vaginal examination, almost 60% were either not informed about why the vaginal examination was needed, they did not provide permission for it to occur, or both. So we view this as kind of our consent indicator about vaginal examinations. And given that, according to WHO, vaginal examinations are intended to occur about every 4 hours, you can see that this can introduce a lot of negative experiences that reverberate throughout the care experiences. We also found that many women experienced neglect during childbirth. So in our sample, about 4.5% of women, again, overcame all these barriers to give birth in the healthcare facility, but they didn't have a provider present with them at the time of birth. And about a third of women who requested pain relief during labor did not receive any pain relief. We were also really interested to explore the timing that certain events took place in relation to the time of birth. So some of the items of mistreatment that we measured were what we called repeat measures, meaning that we collected information about every time that they occurred. So this included instances of specific types of physical abuse, verbal abuse, stigma and discrimination, and we also collected repeated measures on vaginal examination. So every time that one of these events occurred, we recorded information about the events in order to sort of better unpack what was going on. So this graph here shows the odds of an incident of physical abuse or verbal abuse occurring in the 15-minute time intervals relative to 1 hour before birth, adjusting for country and correlation due to the repeat measures. You'll see here the time of birth is that gray dotted line. The red line is verbal abuse and the blue line is physical abuse. So when we adjusted for country differences compared to the period around an hour before birth, women were about 11 times more likely to be physically abused in the 15 minutes before the baby came out, and almost 7 times more likely to be verbally abused in the 15 minutes before birth. So the increased risk during this period might be due to several different reasons. So first of all, it might be because healthcare providers are more likely to be present around the woman as the birth is sort of impending, as the baby's about to come out. It could also be because of the stressors that in the environment that might be influencing healthcare provider behavior. So things like the availability of resources and their own sort of clinical confidence in being able to manage childbirth and complications. But we also know from our qualitative research that midwives and doctors described women as uncooperative during this period, and some justified using physical and verbal abuse as punishment for this non-cooperation and to ensure good outcomes for the baby. So although these concerns about the woman and the baby's well-being might provide a partial explanation for the increased risk during this time period in particular, these behaviors are really actually only likely to worsen women's anxiety, distress, and disempowerment during this time. Okay, next up, let's look at our community survey. So in our community survey, we were able to do this in 12 hospitals across the 4 countries. Again, our data collectors were female and from a non-clinical background, and they were recruited at the health facility for childbirth and then followed up in the community, typically closer to about 8 weeks postpartum. This was an interviewer-administered survey that was based on a tablet, and over 2,600 women participated in the survey. So again, on the right here, we've got a bit of a flow of what our workflow looked like from the time that women were recruited at the healthcare facility up top, retrieved her contact details and started the informed consent process, and then following up with her with their community research team after the birth to schedule a time to come to her and meet with her to discuss what happened during her birth, reaffirming consent, and so on. So in our community survey, about 35% of women reported experiencing physical abuse, verbal abuse, or discrimination, so quite similar to the findings from the labor observations. About half of women did not consent to vaginal examinations before they were conducted. About 16% felt that they were ignored, neglected, or that their presence was a nuisance to the health workers. And about 5% of women reported that they or their babies were detained in the health facility due to their inability to pay the bill. So this means that the woman or the baby would be held and not able to leave the health facility premises until her or her family were able to come up with the money to pay the bill to allow her to be discharged. We also found some really profound inequities in women's experiences of mistreatment. And so we found that younger women were almost twice as likely to experience physical abuse compared to older women. So younger women in our study were women aged 15 to 24 compared to their older counterparts, 25 and above. We also found that younger women with no education were about 3.5 times more likely to experience verbal abuse compared to younger women with education. So some really important sort of age-specific and education-specific drivers here in terms of who's experiencing the worst or the most mistreatment. We also found a lot of instances of unconsented care in the community surveys. So we found that about 11% of women who had a cesarean section reported that they didn't consent before it. Over half of women had episiotomy without consent. And about 27% had induction of labor without any consent. Okay, so now we're just going to spend the next little bit talking a bit about what do we do with this evidence and why does it matter. So I hope that we're starting to understand now why measuring experiences of care matter. We did a secondary analysis from our data to explore the relationship between women experiencing mistreatment and their self-reported satisfaction of care using the community survey data. And what we found here was, as I mentioned, over a third of women in the survey reported experiences of physical or verbal abuse or discrimination. But we also found in the same sample that over 88% of women reported being very satisfied or satisfied with care. So this sounds like a little bit contradictory. But we also know from our qualitative research in each of the same care environments that women really highly valued respectful care. And so we interpret this to mean that these findings sort of between high levels of reported mistreatment, sort of correlating with high levels of satisfaction with care, suggests that there's probably low expectations about the healthcare encounter that are driving this high satisfaction in the context where there's also high levels of mistreatment. We also saw that women who reported verbal abuse were about 4.5 times more likely to report that they were dissatisfied with their care. And so what we took this to mean is that if we only measure satisfaction measures, which as we know are a lot more common than experience measures, we're really going to be missing a key driver of what's contributing to dissatisfaction with care. And as a reminder from earlier in this talk, measuring women's experiences are process measures. And these process measures can help health systems to identify and respond to root causes of dissatisfaction and negative experiences. Okay, so as we know, research doesn't end just with the publication. It's really just the beginning of the next steps. So in these next few slides, I'm going to walk you through some of the impacts and translation that I'm most proud of from the work that we've discussed today. And importantly to note that, of course, these are not all my achievements. These are things from our very, very large team working really hard across many countries across the world. So we'll go through a couple of different levels of impact: national level, global impact, as well as research capacity strengthening impact. So let's start with national level impact. So here I have a quote from Fatoumata Touré, who's the president of the National Association of Nurses of Guinea and was one of our sort of translation experts for Guinea. And Fatoumata says, "We often hear that women were experiencing these issues in Guinea, but this research gave us the truth. It's not the objective of childbirth for women to be treated with violence. We saw this study as a chance to move forward, to put a plan of action in place and improve respectful care for women." So this was a really powerful quote to me because it's sort of someone representing the Professional Association of Nurses in Guinea and really trying to take this research not as a sort of condemnation of nurses or midwives who are working in care, but really to try to take measures to improve respectful care for all. So in Guinea, we were really lucky to be supported by a really strong local team that was from called Sergi. It's based at one of the universities in Conakry. And Sergi brought together the health ministry officials, along with directors of the maternity hospitals across the country, NGOs working in maternal health, professional associations, and international agencies, including WHO. And they facilitated a workshop, a translation workshop, where we presented the findings of the research in Conakry and worked together to sort of co-design a set of recommendations that could be implemented at a national level to reduce mistreatment during childbirth in Guinea. And so some of these national recommendations that were prioritized centered around allowing birth companions, allowing women to have different birth positions of their choice, strengthening training related to respectful maternity care, and improving governance and oversight to improve accountability. One of the most important things I think is that the National Teaching Hospital in Conakry, Hôpital Ignace Dine, now allows birth companions for all women. And so this is really exciting to me because this means that midwives, nurses, and doctors who have to go through training at the National Hospital are going to become exposed to birth companionship as the norm early on in their training. And I really do hope that this will translate sort of upstream to where they work after working in the National Maternity Hospital. Lastly, in Guinea, one of the other sort of major achievements was the team in this workshop also working to have a national indicator on mistreatment that's reported as part of their ongoing monitoring and evaluation. In terms of a global impact, there's sort of three things that I wanted to focus on today. The first was that the WHO Intrapartum Care Guideline has the first ever recommendations on the respectful maternity care, labor companionship, and effective communication. And this is really important to us because it helped us to sort of humanize what these clinical recommendations are and to look beyond the clinical dynamic to ensure that women have access to respectful care, adequate communication, and labor companionship. We were also really lucky to participate in an investigation from the United Nations Special Rapporteur on Violence Against Women. And in 2019, she had this topic of her investigation was on mistreatment during childbirth as a public health and human rights issue. And she developed a report based on our engagement that she then presented to the United Nations General Assembly. And lastly, some of you will be familiar with the new World Health Organization Labor Care Guide. This Labor Care Guide came out in 2020 and is designed to replace the Partigraph as a tool to monitor women during labor. And in the Labor Care Guide, we tried to sort of take the recommendations from the Intrapartum Care Guideline and translate that into something that was really tangible. So the new Labor Care Guide also has prompts for healthcare providers to be checking if the woman has a labor companion available, that's to ensure that she's offered pain relief. She's encouraged to mobilize, use different birth positions of her choice, have improved communication, as well as access to oral food and fluids, which is really, really exciting. Lastly, our research capacity strengthening is something that's really important to me as a researcher. It was really important and embedded throughout our project here. So research capacity strengthening means that we were working with our country teams in each site to develop plans to strengthen the abilities of both individual researchers working there, as well as collectively as research teams. Practically speaking, this really meant sort of a big investment of time and effort around research training. This is often sort of in the development around short courses on data collection, data analysis, and scientific writing. So some of the tangible things that we did were supporting each team to have at least one, and in some cases, many more publications using both the qualitative and quantitative data from the multi-country data set or from the country-specific data sets. We also were supporting each team to sort of complete the research cycle. So we didn't want them to be viewed as sort of just data collectors for this project. We wanted to support them through with data analysis, with writing, and translation to something tangible at the policy level in their context. We also supported people to have research higher degrees. I'm really proud that we had throughout this project 3 MPH research projects and 5 PhD dissertations, including me, as well as one of our country principal investigators, another PopFam PhD alumni. So these are some of the sorts of things that we sort of did after the research project to be translating from our research findings into real impact. So where do we go from here? Our portfolio of work on measuring and reducing mistreatment and promoting respectful care really parallels the core drivers of understanding how complex systems and norms influence the way that women are treated during pregnancy and birth. We really don't know what we don't measure. So if I can leave you here with one thing today, if we align our priorities to better amplify the voices of women and communities, we believe that we can act for a better future for all. But to do this meaningfully, we have to account for these complex social norms around gender, race, and power dynamics, as well as address inequalities to ensure that all people can actualize their right to respectful care. I also want to note that women and communities really know what's most important to them, so engaging in participatory partnerships to find out and make sure that our research is achieving their goals is really crucial. Today, we started from a place where we really didn't know how to measure mistreatment well. We've made substantial progress in this area, but there's still a lot of work to do to ensure that interventions aimed to reduce mistreatment and promote respectful care account for these complex drivers. If we ignore this complexity, then we really risk contributing to worsened health inequities. So I'll stop there. Thank you so much for having me today. It's been an honor and a privilege to chat with you about my work. Please be in touch with any comments, questions, or to chat further. I'd really love to hear from you, and really happy to open up to any questions from the group here today. Thank you.
Wonderful presentation, and thank you for really sharing that whole process of from your real interest and your passion in this topic through the multiple research steps. And I know there's been subsequent work to what you talked about. And, I think this is just sort of a great example. It looks like Celia has a question, but I wanted to know if there's a student first who has a potential question, because I want to prioritize students' questions. So I'm checking the chat. And I'm trying to see if there's any questions that come from the chat. I guess not. So Celia, go ahead. Oh, wait a minute. Yeah, go ahead, Celia.
Thanks, Donna. Thanks so much, Megan. This was such a fantastic and comprehensive presentation. I've loved following your work and have learned so much from you. I just wanted to learn a little bit more about the labor observation piece of it, because I know that from a study design perspective, that can be really complicated to both reduce bias and also get, buy-in from the health facilities. So I was wondering if you could share a little bit about that. I know you discussed how the observers were selected, but did your team encounter any, resistance from health facilities in terms of having kind of someone else in the space? And if so, how did they navigate that? And then also, I was initially thinking, okay, this is going to result in a lot of bias in your sample that people would be reacting differently, more social desirability kind of bias or bystander bias there. But obviously, you saw plenty of mistreatment in your study. So I guess mostly focus on that first question about kind of feasibility and how do you navigate that. Thanks so much.
Great, thanks, Celia. It's a good question because it was a really labor-intensive method of data collection and also method of analysis, particularly given the repeated measures that we were looking at. So in response to your question about if we encountered any resistance, there was quite a bit at the beginning from sort of usually the people who were in charge of labor wards, so typically a matron in charge and head of obstetrics. And we sort of dealt with that just by patients' time, meetings, discussions with them to try to sort of understand what the issue was. So when we first started this training, it was a bit of a different context probably than it is now. For some, they said this is the first time that they were hearing about these issues. But then when we probed a bit of, oh, have you ever heard of someone, making these types of comments or, about specific acts that were happening, then they were sort of like, okay, yeah, we know that that's something that happens, and we're a bit sort of more understanding of what we were doing. A lot of these discussions were navigated and mediated by our country teams, with sort of us supporting from behind, which I think was really important for local buy-in, that at the time I was at WHO, that it wasn't WHO coming in to condemn the hospital as being a terrible site or something like this, but it was actually more about looking at ways that we can better measure and then aim for better quality of care for women and hopefully a better working environment for them as well. So we were obviously also really interested in whether there was a risk of social desirability bias, which we thought was potentially going to be quite high. We had learned from other research that had been conducted in this area by Kate Ramsey that they felt that sort of any change behaviors might have dropped off after about a week or 10 days or so. And so we were really interested to record this also potentially if we needed to drop the first couple of weeks of data collection, which we were a bit reluctant to do given how much work it actually is to get that data. But so what we did in our primary analysis is we explored by week of data collection of the different prevalence of mistreatment items. And we really found that there wasn't really any difference at all. I was actually quite surprised by this. Like I was kind of under the impression, okay, like we probably need to over recruit because we're probably going to have to drop the first couple of weeks of data collection because it's just going to be a complete mess. But we really didn't find any sort of significant differences there, which I think is really a testament to how ingrained these behaviors are, that there isn't always sort of recognition that what's happening and the approaches that are used are wrong, or that there's something sort of out of order with them. I think those are probably the main things, but I'm really happy to chat with you more about the labor observations and sort of what's the additional learning that you can have from them versus, just listening to women's experiences, which are profound and true in their own realities and probably the most important indicators we should be looking at for mistreatment.
So it looks
Thanks so
like
much.
Allison has a question that she raised in the chat. Allison, do you want to ask it? It's probably better to have you
Sure,
ask
my
it than
kids
I
are
doing
home,
it.
so you might hear cartoons in the background. But yeah, a great presentation. I'm really interested in, I'm glad you looked at norms, and I'm really curious about how norms might differ across contexts, and if there's been any further work looking beyond the countries that you studied. And I guess I was just thinking too about norms around what might happen in a facility, but also norms that happen at childbirth that takes place at home. Maybe there's similar treatment that goes on. I wonder if you might comment on that too. Thanks.
Yeah, I might just start with your second point. Thanks, Allison. It's great questions. We had sort of lengthy discussions with some of the midwives in particular about the context of care, and particularly in places like, well, I guess actually all of the countries that we were working in had sort of high prevalence of women still giving birth at home, and of course, historically as well. And in a lot of those settings, the sort of treatment that women would have from traditional birth attendants wasn't necessarily something that was sort of a very kind and caring and supportive or empowering environment for women. Like in some cases, it might be, but it's just certainly not in all cases. And I mean, I guess maybe just as a personal anecdote, I did my master's, my second internship for my master's in Eastern Sudan. And in the communities there, when women were there was no hospitals, and when women were in labor, they would walk out to the furthest place that they could get to while they're in labor, and then squat down, have their baby, and then when they got the strength, walk back home. So they actually weren't supported sort of in the slightest, whether they were in the hospital because they had a complication or if they were sort of at home. So I do think that there's medicalization of pregnancy and birth is definitely a serious issue, and over medicalization. But I do think that there's a bit of romanticizing about what actually happens during births in community. And that's not going to be true in all settings, but it's certainly not a warm and loving place in every place around the world. I guess sort of thinking about other work that's ongoing, related to social norms. I think that there is in other settings, and as you said, there social norms around what sort of appropriate treatment and not is really interesting, and will differ across settings. I mean, the structure and historical context in which the care is provided is also really important to unpack. So as an example, we're working with the team in the country of Georgia now, which has a health system that's structured from the former Soviet Union, and very technocratic approach to providing maternity care that really doesn't think about the individual, but more about the collective. And in this case, the collective is the healthcare providers. So what works for them is what works for the system, and no one sort of gets to say about that. So we haven't started that work yet. That's this year's challenge. So maybe we'll have more to say about that soon, but I absolutely agree with you that sort of unpacking this historical context to understand why these gender norms, why these social norms contribute to poor care is really important.
So Lilu had a question, and she wondered whether or not the reporting differed based on the birth outcome.
Yeah, great question. So in our analysis, we had, well, sort of comparatively speaking, we had a high rate of poor neonatal outcomes. The number was too small for us to explore this meaningfully from a statistical perspective. I would say, sort of based on the work that we had from our qualitative research, that it could be likely that there are particular types of mistreatment that might be more experienced by women who have a stillbirth or who have an early neonatal death, particularly around this threat of poor outcomes for the baby, and blaming women for, you weren't pushing, so that's why this happened, which would be absolutely devastating to place that blame on a woman for something that's outside of her control. So definitely a future research question, I think, a particular group that might be experiencing worse care.
So it looks like David Page had a question about whether or not you saw differences in neonatal outcomes based on the report of physical or verbal abuse. And if I remember correctly, based on some Blair's work, that you actually didn't measure those outcomes. Am I correct?
We do have the baby outcomes, but the number of neonatal deaths were too small really to do something meaningful in that analysis, which I mean is a good thing from a public health perspective, but it unfortunately doesn't answer those research questions that we do have.
So any other questions? So in terms of the norms that Allison raises, you know, I'm thinking about some of the work that Blair did and looking at sort of differences in the scales and the measurement across countries. And she did find, I think, some differences, maybe not statistically significant, but probably reflect the norms.
Yeah, and I think Blair's work was really important to us to be able to unpack what the sort of shortened items would look like on a scale that could be integrated into other ongoing measurement. And what we sort of viewed the next steps of that work as is to be able to integrate a shorter version of a tool into other things like that were integrated into other sort of women's health research that could then unpack sort of at the front end of the survey what some of these complex social norms were. But, you know, sort of we did have a lot of data and across multiple countries, but the main purpose of the study was to develop the measurement tools and then sort of look for the research translational impacts later down the line.
Great. I think McCain has a question, and maybe Cynthia, is that the last one we can take? Yeah, so McCain, you're going to end the questions.
Oh, such pressure. Thank you. Sorry, I'm in a cafe, so I'm not gonna put on my well, I guess I can. That's just weird background. Okay. Thank you for this. I had a kind of a similar question to David, and I think maybe you just answered it. But so it sounds like this is sort of like the development of the tool phase, and the next step is sort of looking at how those those as you measure them, how that impacts outcomes for both moms and babies. Is that right? Yeah.
Yeah, that's exactly right. So I guess sort of our big picture dreaming is to be able to better have these measures about women's experiences of care integrated into things like routine monitoring and evaluation. So this measurement phase was like the really important part to get those measures right and know what we're measuring, understand what it is that we're measuring. And the sort of, for those who are sort of familiar with the maternal health work at WHO, there's been a series of multi-country studies in sort of 20 to 50 countries at a time, looking at different sorts of things that have historically focused on sort of really the epidemiological and clinical outcomes from pregnancy and birth. And we're really trying our best to integrate some measure of having women's experiences there to sort of, you know, move forward from, I guess, sort of the more historical epi focus into something that we can translate into improving women's experiences.
So Meghan, I want to thank you so much for joining us. Cynthia says it was a privilege to have you come back and how impressive your work is. And I want to thank you so much for joining us at 4 o'clock in the morning. You're particularly alert given that it's that time in Australia. You may not feel alert, but you certainly have answered the questions very well. And what I loved was, you know, you're being able to describe the process from being a student, you know, doing the work through the department, moving on to WHO, your work now, how it's contributed to, you know, additional students' work. So I just absolutely wonderful and great to see you again and to talk with you, even if it is 4 o'clock in the morning.
Great. Thank you so much. And thank you for having me, Donna and Cynthia. Nice to see you.
Great. It was a pleasure. Thank you.